Welcome to this video on Stemi, Diagnosis and Emergency Management, based on the Tintinelli and Rosencore frameworks. I am Dr. Nasser Hassan, an EM consultant and educator. We will begin with the pathophysiology, focusing on understanding the acute thrombotic event that causes a Stemi. The core mechanism of occlusion is plaque rupture, exposing the necrotic core and triggering an acute thrombus. Platelet aggregation forms the thrombus, leading to transmural ischemia. Myocyte death is time-dependent, occurring within 20 minutes of occlusion. The clinical presentation includes typical symptoms like retrosternal pressure and radiation to the arm, jaw, or epigastrium. Equivalents, such as dyspnea or profound fatigue, are often seen in women, the elderly, and diabetics. High-risk patients may present with syncope or cardiac arrest. ECG diagnostic criteria for Stemi vary by population. For men under 40, 2.5 mm elevation in V2, V3 is required. For all other leads, the criterion is 1.0 mm for all populations. Remember, elevation must be present in at least 2 contiguous leads. Stemi equivalents and mimics include Wellens syndrome, indicated by deeply inverted or biphasic T waves in V2, V3, suggesting critical LAD stenosis. The Scarbosa criteria is used for Stemi diagnosis with LBBB or paced rhythms, requiring concordant ST elevation of 1 mm or more. Immediate ED management involves several key interventions. Administer aspirin 325 mg chewed and nitroglycerin 0.4 mg sublingually every 5 minutes, with caution for RV infarcts. Give oxygen to keep saturation above 90%, avoiding hyperoxia. Morphine can be used for refractory pain, and serial ECGs every 10 to 15 minutes are necessary if the diagnosis is uncertain. Reperfusion strategies prioritize primary PCI, the gold standard, with a goal of a door-to-balloon time of less than 90 minutes. Fibrinolysis is an alternative if PCI is unavailable within 120 minutes, aiming for a door-to-needle time of less than 30 minutes. Contraindications for fibrinolysis, especially bleeding risk, must be rigorously screened. Adjunctive pharmacotherapy includes P2Y12 inhibitors, like ticagrelor or clopidogrel, to prevent stent thrombosis. Anticoagulants, such as UFH or enoxaparin, maintain vessel patency. High-dose statins, like atorvastatin 80 mg, stabilize plaque. Beta-blockers, such as metoprolol or atenolol, decrease myocardial oxygen demand but should be avoided in shock. Right ventricle infarcts are present in 40% of inferior MIs, characterized by hypotension, JVP distension, and clear lungs. Crucially, avoid nitrates and treat with IV fluids. Posterior MIs show isolated ST depression in V1, V3 with tall R waves and are confirmed by V7, V9 leads. Common Stemi complications include acute heart failure at 25%, arrhythmias like VF or VT at 15%, and cardiogenic shock at 10%. Mechanical complications, such as papillary muscle or septal rupture, typically peak at 3 to 5 days post-infarct. Thank you for watching this video. For any questions or discussion, please feel free to reach out via email. These are the image sources used in the video.